The call comes in for weakness. That's it, just weakness. It's a 58-year-old man, no chest pain, no trouble breathing. It feels like the definition of a routine call, right up until the moment you put him on the monitor and see this. Tall, symmetrical, and possibly sharp T waves, and they don't quite look like other causes of big T waves. This is the first quiet warning of hyperkalemia, too much serum potassium. It's one of the most dangerous and deceptive conditions you will ever face, and it doesn't announce itself. What you decide to do in the next 5 minutes, based on nothing more than these subtle electrical shapes, will determine if this patient remains stable or spirals into cardiac arrest. This isn't just weakness. It's a race against poison that's shutting down the heart from the inside out. I'm going to break down how to spot the silent killer, understand what it's doing to your patient, and know exactly how to fight back in the moments that matter most. So what is hyperkalemia? Sure, the textbook defines it as a potassium level over 5 or 5.5 milliequivalents per liter, depending on the lab. But in the back of an ambulance, that number's meaningless. What matters is what that excess potassium is doing to the heart. Think of it this way. Potassium is fundamental to the electrical system of every muscle. The heart, in particular, relies on a perfect potassium balance to beat correctly, to contract and relax. But when that balance is thrown off, the heart's muscle cells become dangerously irritable and electrically unstable. The entire system is primed to fire at the slightest provocation, but it struggles to reset. That deadly combination of irritability and slow recovery is the real problem. And this is what makes it so terrifying. The symptoms are things you hear all day on almost every kind of call. Muscle weakness, fatigue, nausea, maybe some weird tingling. There's no single blaring red flag. It hides behind the mask of simple, everyday complaints while methodically poisoning the heart's conduction system, setting it up for catastrophic, sudden failure. The only thing that can easily see through the disguise is your EKG. It's your only window into the crisis unfolding inside those heart cells. Your cardiac monitor tells a story, and in hyperkalemia, the progression of that story is often eerily predictable. You just have to know how to read the chapters. This is your first clue, the inciting incident. Around a potassium level of 5.5 to 6.5, T waves get tall, skinny, and pointy. Narrow base, steep sides, pointed tops. Like skyscrapers, not mountains. A normal T wave is broad and rounded. This is not that. Hyperacute T waves, like from ischemia, are big, but also broad-based. The T waves from hyperK are sharp and symmetrical. The moment you see this, hyperkalemia needs to be at the very top of your mind. As potassium climbs towards 6.5 to 7.5, the atria start to give up. They're incredibly sensitive to potassium. The P wave, which shows the atria firing, begin to flatten, stretch out, and eventually just vanish. At the same time, the PR interval gets longer and longer. You're watching the atria become paralyzed in real time. This is a sign of extreme danger. This is often a pre-arrest finding. Once potassium gets above 7.0, the ventricles themselves start to fail. The QRS complex, the signal of the ventricles contracting, gets wider and wider and wider. This is a massive red flag that conduction is slowing down everywhere. The heart is losing its ability to squeeze. When you see this, the situation has become critical. This also leads us to a different trigger for us. Anytime you see AIVR, accelerated idioventricular rhythm, think of potassium. This can actually be simulated from a wide QRS and flat P waves. It's not actually AIVR, it's a potassium waveform. But keep in mind, potassium might be the cause of that AIVR. This is the final page before the story ends in cardiac arrest. At levels above 8.0, the wide QRS just melts into the T wave. You can't tell what's what. It begins from a diagonal line from the bottom of the S wave to the top of the T wave. Then it's just a smooth, rolling sine wave pattern. This is a pre-terminal rhythm. The heart has lost all organization. Ventricular fibrillation or asystole are moments away. If you see a sine wave, you're not minutes away from a cardiac arrest, you're seconds away. When you see these EKG changes, your mind should build a profile of the likely culprits. Who's our number one suspect? Renal failure is the big one. The classic patient is someone with end-stage renal disease who missed a dialysis appointment. Dialysis is what filters out potassium. Without it, the levels climb, and they can climb fast. Ask about kidney problems. Ask about their dialysis schedule. Look for the physical evidence, the AV fistulas in the arm or the catheters in the chest. Another major cause, massive cell destruction. Think crush injuries or rhabdomyolysis from someone who was down for a long time. When muscle cells are destroyed, they rupture and dump all of their internal potassium into the blood. Be incredibly suspicious in any patient with significant trauma or prolonged downtime. Other triggers can include diabetic ketoacidosis, DKA, or certain medications, specifically potassium-sparing diuretics like Lasix, or some blood pressure meds like ACE inhibitors. A good history is just as important as reading the EKG. Okay, you've spotted the EKG changes. It's time to act. Your mission is simple. First, protect the heart. Second, buy time by shifting potassium back into the cells. Notice we didn't say remove potassium. We can't do that. That's a job for the dialysis machine at the hospital. Our job is to pull the patient back from the edge. Your first, most important, must-give treatment for any EKG change is calcium. Think of calcium as a shield for the heart. It doesn't lower potassium level, but it immediately counteracts potassium's toxic effects on the heart muscle cells. It makes them more resilient and less likely to descend into a fatal rhythm. This is the drug that will narrow wide QRS and stop the slide into VFib. You'll likely have two options: calcium chloride or calcium gluconate. Calcium chloride is more potent, but it's harsh and can destroy a vein if the IV infiltrates. It needs to be in a big, reliable IV and pushed slowly. The standard 1 gram dose should be given over 5 to 10 minutes. Calcium gluconate is much safer for peripheral veins, but you need to give a bigger dose, usually 3 grams, to get the same cardiac protection. Know your own protocols about triggering treatments and base contact or whatever. But when you see those EKG changes, think calcium. Give calcium. After you've shielded the heart, you work on shifting the potassium back to inside the cells from the serum. High-dose albuterol is a great tool. We're not talking about a standard asthma treatment. We're talking about 10 to 20 milligrams nebulized, 4 to 8 times the normal dose. The albuterol stimulates receptors that activate pumps on the cell surfaces, which pull potassium out of the blood and back into cells. You can even start this before you have an IV. You probably don't have enough albuterol in your bus, but you can start the process. And when you arrive at the hospital, you having a patient on albuterol means that everyone recognizes you've read a book. Sodium bicarbonate is another tool, though it's best for patients you know are acidotic, like in DKA or some renal failure cases. The idea is that raising the blood's pH will drive potassium back into the cells. The typical dose is 1 50 milliequivalent amp. It's falling out of favor for routine Hyper-K treatment, but it works when the QRS is wide. Some advanced systems might even carry insulin and dextrose. Insulin is a powerful key that unlocks the cells and lets potassium rush in. You give it with sugar, dextrose, to make sure that you don't bottom out the patient's blood sugar. This is incredibly effective, but requires very careful monitoring. Knowing what to give is one thing. Knowing why and when is what makes you a great clinician. Understanding the dance between these EKG changes and the specific drugs is a skill that saves lives. If you want to see more breakdowns of field medicine like this, make sure you subscribe so you don't miss what's next. Let's go back to our 58-year-old man. You're only a few minutes into the call, but you're already seeing the story evolve on the screen. The T waves are still sharp, but now the QRS is getting wider. His pressure is dipping. This is the moment. You've already got a large bore IV running. You look at your partner. Grab me an amp of calcium chloride. You draw it up, double check the line, double check the med, and start a slow, deliberate push with your eyes locked on the monitor. For a few long seconds, nothing. The wide, ugly complexes march across the screen. And then you see it. It's subtle at first, but then it's undeniable. The QRS starts to narrow. The sharp T waves lose their peak. The rhythm organizes itself. It's like you can feel the heart take its first clean breath. You did it. You didn't cure him. He still desperately needs a dialysis machine. But you pulled him back from the brink. You shielded his heart, stopped a fatal arrhythmia from happening, and gave the hospital the time it needed to save his life. That's the power of pre-hospital medicine. Hyperkalemia is the definition of a high-risk, low-frequency call. You might not see it for a year, but when you do, you have to be ready. So what's the takeaway? First, use your monitor. The EKG is telling you a story. Learn to read the chapters. The peaked T wave is the warning. The widening QRS is the emergency. Don't wait for the sine wave. Second, know your play. If there are EKG changes, the answer is calcium. Shield the heart first. Then, and only then, you can worry about shifting the potassium with albuterol or bicarb. Vague symptoms can have the deadliest causes. Your EKG can reveal the silent killer hiding in plain sight. Be vigilant, trust your skills, and you will be the difference. This is Angry Bill for Pre-Hospital Wisdom. Until next time, stay safe.